Hello, everyone. My name is Octavio Pontes. I am an associate professor of neurology at the Ribeirão Preto Medical School, University of São Paulo in Brazil. It's my great pleasure and honor to welcome you to this wonderful and very interesting webinar that will approach the current gaps in anticoagulation for stroke prevention with such a high level of speakers, experts in the field that will bring us with the latest on the anticoagulation for stroke prevention. Before I start, I just want to have some housekeeping rules. I want to invite you to please type your questions in the Q&A boxes in your Zoom control panel. I would like to ask you to also use the chat box to say hi or leave your feedback whenever you appropriate. Please participate in our polls, as they are very important for us to understand your knowledge about the field and also the contribution of the webinar. The webinar is being recorded, so everyone can see it again, double check, and also tell other colleagues to watch it afterwards. And please fill in the evaluation survey afterwards so that we can understand the impact on the clinical practice. I just want to also say that this webinar is being supported by an unrestricted grant from Bayer, but we are very happy to have an independent panel that will bring us with their own opinion about the topics. Right now we have we're probably gonna ask you to answer few questions that are helpful for us to understand your previous knowledge about the topic. So the first question would be, please answer, what is your current level of familiarity with antithrombotic strategies for stroke prevention in patients with or without atrial fibrillation? Are you very familiar, somewhat familiar, not familiar with the topic? Please answer your question. I'll give you 30 seconds. All right, almost there. Okay, the second question would be, how would you describe your level of understanding of how the mechanism of action of factor 11 and 11A inhibitors are hypothesized to uncouple hemostasis from thrombosis? How would you describe your level of understanding? I see folks from everywhere. That's great. We have people from all over the world join us right now. It's wonderful. Please answer the second question, guys. More 15 seconds. All right, let's go to the third question. It's how would you describe your level of awareness of the current phase 3 trials investigating factor 11 and 11 activated 11 factor inhibition? Are you no awareness of the trial, some awareness? Are you aware, above the average, or are you expert in the field of trials about factor 11? Thirty seconds. Okay. Then, in your opinion, what are the top 3 unmet needs with antithrombotic therapy providing protection from recurrent ischemic strokes in patients who are also at high risk of bleeding, irrespective of AF diagnosis? You can choose multiple questions here, please. You reducing the increased risk of bleeding, being able to offer better protection for recurrent ischemic stroke to patients who are undertreated due to bleeding risk, improve reduction in the risk of recurrent ischemic stroke without increasing the risk of major bleeding, increasing efficacy in preventing thromboembolic events, patient awareness and understanding of benefits of treatment, better dietary and lifestyle management tools, and support programs, and better use of existing treatments. Then we have the fifth question is, how confident are you in the balancing risks and benefits of antithrombotic therapies in AF and non-cardiomyopathic ischemic stroke patients? And finally, we have the sixth question. How familiar are you with the use of cardiac biomarkers to guide antithrombotic therapies for prevention of recurrent stroke? So that's the questions we're going to be approaching right now with this wonderful panel of speakers. And for now, I would like to introduce you. Okay, let's see the pool results. So basically, we have 50 to 40. So most of the people are very familiar, somewhat familiar with the strategies for stroke prevention. Some awareness of the level of understanding about the mechanism of action of factor 11. We have no awareness or some awareness of the phase 3 trials that are investigating factor 11 and factor 11A. And most of the people think that reducing the increased risk of bleeding in treated patients, being able to offer better protection for recurrent ischemic stroke and improve reduction of the risk of recurrent stroke without increase the risk of major bleeding are the main three unmet needs. Most of the people is somewhat confident in balancing the risk of benefit of thrombotic therapies in AF in non-cardiomyopathic ischemic stroke patients. And most of the people is not familiar with cardiac biomarkers to guide thrombotic therapies. All right, so very exciting. And now it's my great pleasure to introduce for the first call, Professor Jeffrey Weitz is the professor of medicine and biochemistry and biomedical science at McMaster University, executive director of the Thrombosis and Atherosclerosis Research Institute in Canada. And Professor Weitz will talk about anticoagulation pathways that dissociate thrombosis from hemostasis. Thank you so much for your time, your disponibility, Professor Weitz. It's a great pleasure to have you on board.
Thank you so much for inviting me. So I'm going to talk about anticoagulation pathways that dissociate thrombosis from hemostasis. These are my disclosures. I'll give you a moment to look at them. I'm going to start here by explaining to you that there are two distinct pathways by which coagulation can be activated. There's the tissue factor-driven extrinsic pathway. This is the pathway that's initiated when atherosclerotic plaques are disrupted. There's also the contact-driven intrinsic pathway. This is the pathway that's initiated when blood comes into contact with foreign surfaces such as intravascular stents, mechanical heart valves, or central venous catheters. The intrinsic and extrinsic pathways converge at the level of factor 10 to form the common pathway, which involves factor 10A conversion of prothrombin to thrombin and subsequent thrombin-driven clot formation. Now, our current anticoagulants all target the common pathway. We have the oral factor 10A inhibitors, we have an oral thrombin inhibitor, and even warfarin reduces the synthesis of clotting factors in the common pathway, namely factor 10 and prothrombin. But current interest has focused on factor 11, and the purpose of my presentation is to tell you why that has occurred. If we look at the left side of this figure, I'm showing you the events that occur in hemostasis. Hemostasis is predominantly an extravascular process that is designed to plug holes in the vasculature to prevent bleeding. And this process is driven by the high concentrations of tissue factor that surround the blood vessel in the hemostatic envelope. And this hemostatic envelope is particularly rich in tissue factor in the vessels in the brain. These large concentrations of tissue factor trigger explosive thrombin generation and fibrin formation. And of course, thrombin is also a potent platelet agonist, so that induces platelet aggregation. Now, with this explosive clot formation, there is no need for factor 11 in most cases. Contrast this to the right side of the plot of the graph here, where you see thrombosis. Thrombosis is intravascular clot formation, and this is triggered by small amounts of tissue factor that might be exposed, for example, here at the site of a plaque rupture. The plaque rupture exposes small amounts of tissue factor, which generate small amounts of thrombin and small amounts of fibrin. The fibrin covers up the injury site. So for that clot to grow, thrombin needs to feed back, activate factor 11 to generate more factor 10A and more thrombin. So if you look here, you can see that factor 11 is essential for thrombus growth, intravascular thrombus growth, but mostly dispensable for hemostasis. Now, the direct oral anticoagulants, whether they're oral factor 10A or thrombin inhibitors, they target factor 10A or thrombin, which are part of the common pathway. So they affect hemostasis and thrombosis equally. Therefore, use of these agents cannot dissociate between the two processes, and inevitably, bleeding will result. Now, factor 11, as we've said, is critical for thrombosis, but mostly dispensable for hemostasis. And we have inhibitors that either block factor 11 activation or block factor 11A activity. And these agents preferentially attenuate thrombosis with little effect on hemostasis. Now, what's the evidence supporting the differential effect of factor 11 on thrombosis versus hemostasis? Well, first, subjects who have congenital deficiency of factor 11 have a reduced risk of thrombosis and rarely experience spontaneous bleeding. We have genetic epidemiology studies involving large cohorts of subjects that show that the risk of thrombosis is about twofold higher in individuals who have high levels of factor 11 compared with those who have normal levels, and the risk of thrombosis is lower in those with reduced factor 11 levels, yet subjects with reduced factor 11 levels do not report spontaneous bleeding. And finally, studies in animals show that factor 11 inhibition attenuates thrombosis in rodents and non-human primates without increasing the risk of bleeding. And this is very different from what we saw with the DOACs, for example, in animal studies. The DOACs reduced thrombosis in a dose-dependent manner, but with increasing doses, there was more bleeding. Not so with the factor 11 inhibitors. Now, the factor 11 inhibitors come in different flavors. We have antisense oligonucleotides that reduce the hepatic synthesis of factor 11, thereby reducing systemic factor 11 levels and creating a situation much like congenital factor 11 deficiency. We have monoclonal antibodies that bind to factor 11 and block its activation or block its activity. And we have small molecules with asundexian and milvexian being the most advanced in development. And these small molecules act much like the DOACs to bind reversibly to the active site of factor 11A and block its activity. Traditionally, the development of new anticoagulants starts in patients undergoing orthopedic surgery because such patients are at risk of thrombosis if thromboprophylaxis is not given. And even with state-of-the-art thromboprophylaxis like enoxaparin, there still remains a risk of asymptomatic deep vein thrombosis, which can be detected by routine venography, routine x-rays of the veins, done about 10 to 12 days after the surgery. There were 4 factor 11 inhibitors that were tested in patients undergoing elective knee arthroplasty. These include the antisense oligonucleotide, asocimab. This is an antibody that inhibits factor 11A, abelacimab, an antibody that binds to factor 11 and blocks its activation by both factor 12A and thrombin, and milvexian, a small molecule factor 11A inhibitor. And in all of these studies, the factor 11 inhibitors were compared with low molecular weight heparin, enoxaparin, and the risk of postoperative venous thromboembolism, which includes mainly asymptomatic deep vein thrombosis detected by venography, but also any symptomatic events. And overall, there was a 40% reduction in venous thromboembolism with the 11 inhibitors compared with enoxaparin, and a 60% reduction in clinically relevant bleeding, the composite of major and clinically relevant non-major bleeding. So these studies support the concept that factor 11 inhibitors can reduce the risk of thrombosis without increasing the risk of bleeding compared with standard of care anticoagulation. Asundexian, the other small molecule factor 11A inhibitor, was not tested in a knee arthroplasty model. Now let's go over quickly some of the phase 2 data with the factor 11 inhibitors. In the phase 2 Azalea trial with abelacimab, about 1,300 patients with atrial fibrillation at moderate to high risk of ischemic stroke were randomized to one of 2 doses of abelacimab, which was given subcutaneously once monthly, or to rivaroxaban. This was an event-driven study, and the primary outcome was major or clinically relevant non-major bleeding. The study was stopped early because of a significant reduction in major or clinically relevant non-major bleeding with abelacimab compared with rivaroxaban, and the 150 milligram abelacimab dose given once monthly was taken into phase 3. Asundexian was investigated in the phase 2 Pacific clinical trial program. There were 3 trials: the trial in atrial fibrillation, the Pacific AF study, 750 patients with atrial fibrillation randomized to one of 2 doses of asundexian or to apixaban. The Pacific AMI and Pacific stroke studies looked at 3 different doses of asundexian compared with placebo on top of single or dual antiplatelet therapy. And in all of these studies, asundexian was well tolerated. All of the studies were underpowered for efficacy, but the trials revealed good safety of asundexian at these doses. The Pacific AF study showed a significant reduction in bleeding with asundexian compared with apixaban, and the 50 milligram dose was taken forward in the phase 3 Oceanic AF study. And there, asundexian at 50 milligrams once daily was compared with apixaban at the usual doses. The primary efficacy endpoint was stroke or systemic embolism, and the primary safety outcome was ISDH major bleeding. The study was stopped early because of an increased risk of stroke and systemic embolism with asundexian compared with apixaban, about a 4-fold increase in risk. And these results were presented recently at the European Society of Cardiology meeting and published online in the New England Journal of Medicine. Now, what about the milvexian development program? The phase 2 program included the axiomatic TKR study, the total knee replacement study that I showed you in the meta-analysis, as well as a secondary stroke prevention study. And 3 phase 3 trials are underway. In the Librexia stroke and Librexia ACS study, the milvexian at a dose of 25 milligrams twice daily is being compared with placebo on top of single or dual antiplatelet therapy. And in the Librexia AF study, the milvexian at a dose of 100 milligrams twice daily is being compared with apixaban in patients with atrial fibrillation who are at high risk for stroke and for bleeding. There's also a parallel pediatric development program. Now, I want to show you that in the milvexian TKR study, the knee replacement study, milvexian reduced VTE events in a dose-dependent manner, and at total daily doses of 100 milligrams or more, milvexian was superior to enoxaparin for prevention of postoperative VTE. If you see on the right in the green, there was no dose-dependent increase in clinically relevant bleeding with milvexian and no major bleeding events. In a model-based meta-analysis, the higher doses of milvexian, those of 100 milligrams daily or more, were compared with apixaban for prevention of VTE after total knee replacement. This is a model-based analysis, and you can see with the 100 milligrams twice daily dose, the odds ratio favors milvexian over apixaban. And this is the dose that was chosen for phase 3. So if we look at the comparison of dose selection for phase 3 with milvexian and asundexian, in phase 2, milvexian was tested over a 16-fold dose range from 25 milligrams to 400 milligrams daily, whereas asundexian a 5-fold range from 10 milligrams to 50 milligrams. The phase 2 study that prompted the dosing was the knee replacement study for milvexian and the Pacific AF study for asundexian. The evidence, there was a dose response in terms of efficacy for milvexian. It was a safety outcome for asundexian. And milvexian dose selection was based on the clinical event data, the clinical assay being the activated partial thromboplastin time, and the results of this model-based meta-analysis. Whereas for asundexian, it was this in vitro factor 11A target engagement assay, an assay that was not used with any of the other factor 11 inhibitors. So the doses chosen from phase 2 were for AF, 100 milligrams twice a day for milvexian, 50 milligrams once daily for asundexian. And I think that the reason Oceanic AF failed is because the dose of asundexian was just too low for the AF indication to go head-to-head with apixaban. So we have ongoing phase 3 trials with abelacimab, the LILAC trial is comparing abelacimab with placebo in patients with atrial fibrillation who are deemed unsuitable for oral anticoagulants. And the Astra and Magnolia trials are comparing abelacimab with either apixaban or dalteparin in patients with cancer-associated venous thromboembolism. The Oceanic AF trial was stopped. The Oceanic Stroke study, where the 50 milligram once daily dose is being compared with placebo on top of single or dual antiplatelet therapy, is still ongoing. The target sample size is not as shown here, but it's about 15,000 patients. For milvexian, there's the Librexia AF, stroke, and ACS trials. The AF trial, I say that the target sample size is about 15,500, probably going to increase to around 18,000. Remember again that the AF trial is using milvexian 100 milligrams twice daily, and the two other studies, which are comparing milvexian with placebo on top of antiplatelet therapy, are using a lower dose of 25 milligrams twice daily. So in conclusion, targeting factor 11 has the potential to reduce the burden of thromboembolic cardiovascular diseases while preserving hemostasis, because factor 11 is essential for thrombosis, but mostly redundant for hemostasis. But we need the results of these phase 3 trials to establish the benefit risk profiles of factor 11 or 11A inhibitors. Thank you very much for your attention.
Thank you very much, Jeffrey. Wonderful talk. We're gonna leave the questions to the end. And now it's my great pleasure to introduce Professor Myra Katan, Deputy Director, Department of Neurology of University Hospital in Basel, Switzerland. Professor Katan will talk about atrial fibrillation burden biomarkers and stroke recurrence risk. Thanks so much for your availability.
Thank you very much for this kind introduction. I just will try to share my slides and let me know if you can see them. All fine?
Yes, we can see it very well. Thank you.
Super, wonderful. So very happy to be here and talk about a little different topic, still important in stroke recurrence risk. And I'm talking about AF burden biomarkers and stroke recurrence risk. So why stroke recurrence risk? I think this study is really helpful in looking at why we should look at stroke recurrence risk and how it developed over time. If you see here, this is a large population-based study from South London, and they collected data between 1995 and 2018. And what they did, they looked at the recurrence risk over these decades. And if you look at panel A, you can appreciate that the recurrence risk at 5 years was really reduced actually in the first decade. So in the 1990s up to the 2010. But after that, really in the second part, there is not much of a decrease in stroke recurrence risk. On panel B, however, you see this combined endpoint of stroke recurrence or death. And here you can see a steadily decrease over time in this combined endpoint at 5 years after the first stroke. So what does that mean? Actually, it would say that we are quite good and better in preventing death or complications after stroke in terms of acute treatment than we are in preventing stroke recurrence over time. And in conclusion, I think we could say there is still some room for improvement regarding recurrence rate reduction. Now, coming to the basics, what are actually the main pillars of secondary stroke prevention? So we all know about treatment of important risk factors, which are to be treated in all stroke patients. So if there is hypertension, if there is glucose metabolism disturbance, if there is dysregulation of lipids, inflammation, hypertension, smoking, and so forth, you have to treat them in all our stroke patients. And we know that this reduces stroke recurrence risk very much. But to make it a bit more complicated in stroke, there is also important that the secondary pillar actually of stroke prevention is to look for the underlying mechanism of the stroke. Because as you all know, stroke is a very heterogeneous disease. And it is important to target the most likely mechanism of the recurrent stroke and specifically treat the underlying mechanisms as well, besides the overall vascular risk factors. The problem is, however, it's not always as easy to identify the underlying etiology, and there is a large overlap, meaning it's not so easy as we think to distinguish them according, for example, to the TOES criteria. So this is an example why it might be not as easy to identify the underlying etiology or risks. So here there is the stroke AF RCT, and what you can see and what was really important, I think, in the last decades and shifted our idea is that even if you had an incident stroke due to small vessel disease or due to large arteritic stroke, if you look for underlying atrial fibrillation, you can find it in the same amount as in ESUS patients. So you can see here with the loop recorder, you can identify the same rate of AFib after 12 months as you can in ESUS patients. So actually independent of the initial stroke, you really have underlying risk of cardiac atrial cardiopathy or AF in all these patients. So that means it's important to look for it in everybody. So going back to identify something we know we could probably improve by giving those patients oral anticoagulation would be that we identify underlying not yet detected atrial fibrillation and potentially other sources of covered cardioembolic stroke. And in that regard, to target really those who might have this risk of underlying atrial cardiopathy or AF. And blood biomarkers could really help in identify such patients and identify patients who might have an increased cardiac thrombogenicity risk and thus also a higher risk of stroke recurrence. And the advantage of blood-based biomarkers are actually you don't really have to wait until you have major macroscopic changes. So of course you could look and see if there is a mechanical dysfunction of the atrium. You can see if there is AFib, but you could also use this biomarker even a bit further in the preclinical state and be potentially a bit more sensitive in that regard. Now, several blood-based biomarkers have been studied and looked for to show if there is an association of these biomarkers with atrial fibrillation. Not that much of studies have been done in the stroke population. So there is a plethora of markers which have been looked at to be associated with AF, independent of the population having had a stroke or not. But in the stroke population, there were some studies looking at especially the brain natriuretic peptides. And what you can appreciate here, there is a clear association of, for example, NT-proBNP with cardioembolic stroke. And even there is an association in several studies with newly diagnosed atrial fibrillation after stroke. And one of the largest study, which included specifically ESUS patients, so not the whole population, but ESUS patients, comes from the RESPECT ESUS trial. And here you can see there was an association with newly detected atrial fibrillation after stroke with an odds ratio of 0.7 adjusted for other risk factors. The problem for now with NT-proBNP is that we don't really have an externally clearly validated cutoff for the detection of AF after stroke, because the cutoffs look that vary quite a lot, and that has a bit to do with the design of the studies because they were also heterogeneous. We were more interested also to look at another similar marker, the atrial natriuretic peptide, which has been associated not just with cardioembolic stroke etiology and incident cardioembolic stroke in a population-based study, but there is even potentially a causal link because the gene which encodes for atrial for ANP has a frameshift mutation in patients with familial AF. So there might be even more than just an association, but a causal reference here between atrial natriuretic peptide and atrial fibrillation. We wondered now if mid-regional pro-ANP is also associated not just with cardioembolic stroke etiology cross-sectionally, but also with the most important question we have clinically, is it also associated with newly diagnosed atrial fibrillation on follow-up? And what you can appreciate here is that there is a large association with an odds ratio of 35 with newly detected AF on follow-up with the follow-up time of 12 months. And this even after adjusting for the most important demographic and vascular risk factors. Now the question comes up, of course, we also look at echo parameters and enlargement of the atrium, but still here ANP improved the diagnostic discrimination with an area under the curve of 0.8 for history of AFib, but also newly diagnosed AFib after stroke was clearly identified by measuring that biomarker. So we came up with some suggestions on validated cutoff in the whole stroke population. So not just ESAs, every type of initial stroke. And we came up with these cutoffs to identify patients with lower risk, intermediate risk, and high risk, and to help to allocate resources for prolonged ECG monitoring in all acute ischemic stroke patients. And this validated cutoff have been measured within 24 hours after symptoms onset. So you really short after stroke, you can say in which category the patient falls. We even also looked at stability over the next 5 days. That seems to be the same in predictive value. However, validated was it within 24 hours after symptom onset. So now the question is also, we can identify those with the highest risk, but can we also use those biomarkers to rule out more or less newly diagnosed AF? This is a bit more tricky. It depends on how high of a risk you're willing to take into account. But what you can appreciate here on this slide is also a comparison of MR-ProNP as a biomarker compared to NT-proBNP, and how many tests, so how many long-term ECG monitorings you could avoid by using these biomarkers. So if you look at these curves, you can appreciate that both natriuretic peptides are quite closely together. However, there seems to be a bit more of information when you measure MR-ProNP and a bit more of both biomarkers if you compare it to just clinical data. So you could, reduce your costs in terms of allocation and really try to not do loop recorders, for example, in everybody because it's not really needed potentially. Now, coming to the idea that AF, we have it detected now, all fine. The question really is, if they look the same, but probably not all AF are really the same. Why do I say that? Because there might be something like AF burden, and it depends on potentially your AF burden might be associated with a higher risk of stroke recurrence. So, having one time a short episode of AF maybe doesn't carry the same burden for stroke recurrence as it does if you have often long-term AF. So the question really is also then how to treat these different types of AF burden within the stroke population. We have more information about non-stroke population, about patients who have a high CHA2DS2-VASc score, but not definitely a stroke. And there we can see in some sub-analysis, for example, also of the Artesia trial, that, you know, not everybody with all types of AF may benefit the same from oral anticoagulation. And of course, besides wanting to identify those with highest risk of AF or with low risk of AF, and using those biomarkers to allocate your resources for long-term ECG monitoring, what we really are interested in our stroke patients is, do they have another event? And can we also predict with our biomarker not just the risk of AF, but really the risk of a re-event? And here you can see that there is also an association, dose-dependent, of MR-PRO-AMP with MACE, so a combined endpoint of cardiovascular mortality and stroke recurrence after 1 year. And this is adjusted for several demographic and vascular risk factor. And even if you take into account the competing risk of death using sub-distributional hazards, you see these effects. So then the question probably arises, do we really need to wait for the diagnosis of AF in our stroke patients? Or do we potentially need to identify those patients with the highest risk of underlying cardioembolic sources and the highest risk of stroke recurrence? So having a marker which is associated strongly with underlying atrial cardiopathy and AF burden, but at the same time also associated with stroke recurrence risk. Because if we can identify exactly those, select them high-risk patients, maybe these are the patients who might benefit most from oral anticoagulation. So that's why we're doing a randomized control international trial, trying to guide secondary prevention based on this biomarker and look if strategy A, based compared to strategy B in a 1-to-1 randomization within 7 days of the first stroke, if we could improve our stroke recurrence rate after 365 days based on our selection using this biomarker. So could it be that strategy A, directly giving those patients with a biomarker level above 200 picomole, benefit from oral anticoagulation straight away? Or do we really have to wait in strategy B until we find or do not find AF in these patients who we think have a high burden of underlying atrial cardiopathy or atrial fibrillation? So we will expect these results hopefully in 2 years, and then I can tell you more about this hypothesis. So now a summary of take to work message, so not home, but take it to work. So important. Secondary stroke prevention needs to be improved, and there is still a large residual risk. There are 2 main pillars of secondary prevention for both stroke, and risk factors management and underlying stroke etiology need both to be addressed. Underlying etiology mechanisms can better be captured potentially with the help of blood and other, such as imaging biomarkers. Not all AF potentially is the same, and maybe not all AF needs the same treatment. Biomarkers of not only AF risk, but also recurrence risk may be helpful to guide secondary prevention. But of course, we need RCTs for this information to finally implement these biomarkers in clinical routine. So thank you very much for your attention, and I'll give you free now.
Thank you so much, Mara, for such a wonderful talk, very inspiring and instigating. I will now move, so leave the questions to the end, and I invite you, all the attendees, to leave the questions for Professor Myra as well in the Q&A. And now it's my great pleasure and honor to introduce Professor Valeria Caso, who is a consultant neurologist at the stroke unit at Santa Maria della Misericordia Hospital at the University of Perugia, Italy. Ciao, Valeria. It's a great pleasure to have you with us today. Thank you.
Thank you very much. And thank you for inviting me. So I will speak a little bit more, some more practical points after this two wonderful talks. So these are my disclosure, and I will start with a poll question. I think something that you heard already. You heard about from Mira about this residual risk. And how, according to the questions, according to long-term follow-up data, what is the estimated residual risk for recurring ischemic stroke at 5 years in patients who experience a TIA or a minor stroke despite being on antiplatelets? Sorry, it's a stroke, not only minor stroke. So take your vote. Okay, so there's a interesting distribution. I will tell you the answer at the end. So what is the clinical problem? So we are working in our stroke unit. We're treating our patient. We know that now stroke is beatable. We with our wonderful thrombectomy data and experience that we are making, sometimes we really have major strokes, and we do not even send them to rehabilitation, which honestly, when I started to do this job, I never could think about, to send a patient with an NIH of 20 after a weekend stroke unit directly to at home. But however, the risk of recurrence remain, and it's about 12.8% after TIA, especially after TIA, because this is the condition that you often do not admit at the hospital. You do it in outpatient management, and it is lowered by emergency treatment, and it needs stroke and TIA, the identification of presumed causes. So here we have a typical case that we have in our stroke unit. He was admitted on January 6 p.m. Roberto, a male, 75-year-old. He had a sudden onset of transient mild aphasia, NIH of 2. Nobody realized that he was aphasic, so this is why he came 12 hours from onset. I don't want to make always the political incorrect joke that he's a man and nobody realized that he was not really speaking. So he was admitted. The CT at admission was negative for acute ischemic stroke. He had, as you can see, a high-risk profile with hypertension, diabetes mellitus, smoking, BMI over 25, and treatment with ramipril and metformin. And you see, this is his MRI. Vascular situation was not so bad. But still, what did we do? So we know that in this situation, the different guidelines give us the indication to give dual antiplatelet treatment. And you know that in patient with an NIH score less than 5, and who comes within 12 to 24 hours from symptom onset at least 7 days, this is for the American guidelines, should be treated by DAPT, so double antiplatelet therapy for 20 to be continued to 29 to 19 days, followed then by single antiplatelet therapy. A little bit different is the other European guidelines. So we have non-cardiobolic stroke with an NIH less than 5. The recommendation is to give DAPT of aspirin and ticagrelor for 30 days, dual antiplatelet for aspirin and clopidogrel for 21 days, and then it will be followed by single antiplatelets. For TIA, we have the same indication for aspirin and ticagrelor for 30 days and DAPT with clopidogrel for 21 days. So this is currently what we do in our stroke units. This is about long-term single antiplatelets. Sometimes there can be considered the combination with rivaroxaban low dose of rivaroxaban 2.5 twice daily, especially if we have CAT and PAD, which is in a way a limitation, but due to the indication of the drug, despite we know that this is a very efficacious combination. However, coming back to our friend, he was discharged. He started his loading dose with 300 milligram of clopidogrel with aspirin. Then he had clopidogrel for 75. He was followed by 75 milligram of clopidogrel for 21 days, and then aspirin for long-term treatment. And we gave him all these indications: stop smoking, lose weight, take your statins. This is what what you try to do: some consultation, lifestyle, move more, start to walk, try to have a dog in order to move more. All this wonderful thing that we try to transmit, because we are talking about brain health. However, when he stopped clopidogrel, when he went to DAPT to SAPT, we had a very early recurrence. And this is always, you can imagine, in your stroke you need a defeat because you think we did everything. We followed the guidelines. We gave him, in this case, all the best management that we can offer with all the indication. And what we did wrong. So the question is, clearly there are now plenty of new drugs in the optimal management of vascular risk factors. I will not focus on this, but I will focus on what we have from antithrombotic therapy, which is recommended for nearly every patient. But however, the risk of a second stroke is 9-fold greater in patients who had already a stroke compared to the general population. And the 5-risk risk is 25%. And this is a very strong risk, because if you consider that 1 in 4 will have a recurrence, even if we are doing extremely well with stroke prevention, but we are still not, and you heard this also from Mira, there's still a residual risk that we still need to face, and something that we cannot be happy how we treat our patients. And you see this change, for example, for age. The higher the age, the lower is the reduction of the recurrence. The reduction is worse in females, probably because we tend to be older. Also, the fact that many females live socially isolated, then you don't have all this motivation to do your secondary prevention treatment. So there are many other social, biological reasons why female have a higher recurrence risk. And we know there is clearly an effect of race. And here again, you see the different types of long-term recurrence based on stroke, on TOAST subtypes. And clearly, there is a high recurrence risk for large artery disease, small vessel disease. So, sorry. So this is still... Again, the data that you heard already, still 20% of residual risk at 5 years. So as we have, again, this is another indication that we know that in lacunar stroke, the DAPT may not reduce the recurrent stroke, but increase the risk of bleeding versus aspirin alone. So what we need to understand is what to do in these kind of patients in order to reduce the risk. We know from the COMPASS trial, the combination of 2.5 rivaroxaban twice daily, in addition to aspirin, there is a clear reduction, a 67% and reduction of the rate of ischemic unknown stroke in a subpopulation with cardiac disease. And based on these premise, the Pacific stroke that you heard already from Jeff, the data that led to the Pacific stroke design, first for safety. So what was the searched for in the phase 2 trial was the safety of asundexian in 3 doses plus placebo on top of what is the current treatment. And clearly, the trial objective was to assess the effect of factor 11 inhibition on standard treatment in the reduction of covered brain infarct and recurrent symptomatic brain ischemic stroke. However, in the primary efficacy outcome, it was not reached. There was not a reduction for covered infarct and ischemic stroke. However, again, this was a phase 2 trial, so it was about safety. But still, we had very interesting results showing that there was a reduction in ischemic stroke and TIA when we looked at the group with asundexian 50 milligram versus placebo. So these were post-hoc exploratory endpoint, but very important for the design of the phase 3 trial. And there was a very important, a beneficial trend with asundexian in patients with atherosclerosis for the reduction of risk of ischemic stroke. So again, you heard about the interruption, the premature stop of oceanic AF, which was asundexian alone. We will see if it was the dose. But here you have a completely different rationale, because we are here treating atherosclerotic disease together with the standard care. So working maybe only on the residual risk or also as the treatment in the future. But this is something that we will see with the phase 3. And what we also see, there was a similar proportion of major bleeding events with asundexian versus placebo on top of antiplatelet therapy. So there were less minor bleedings, less major bleedings, and also less microbleeds. Same here, you know, when science is science, and you heard this very well from Jeff also, then you have a repetition of results. So we are talking about the concept of on top of treatment. And you can see the axiomatic trial had similar results compared to the asundexia results. There was again no reduction of covered infarct at 19 days. However, there was a tendency, there was an association with numerically fewer symptomatic ischemic stroke at all doses except the 200 milligram twice daily. So based on this, and I don't want to go too much on this because you heard this already, we have the oceanic stroke ongoing, and still the study is going quite well. The study is running, and the primary efficacy outcome is the time to the first occurrence of ischemic stroke, and clearly this primary safety outcome is time of the first occurrence of major bleeding. Same here, we have the Librexia stroke, which is ongoing. And you can see there are differences in the selection of the patients, but globally, it's the primary outcome in this case is time to the first occurrence of ischemic stroke. So in summary, what we saw, and I think this is very promising, asundexian and milvexian were associated with fewer ischemic stroke and with no significant increase in major bleeding. In the secondary analysis of Pacific stroke, the rates of new microbleeds, hemorrhagic transformation, and intracranial hemorrhages were numerically less in patients on asundexian versus placebo. And again, patients who were already on DAPT, SAPT. So not there was almost a triple therapy in acute stroke, which is very well known by cardiologists, but less known by neurologists. And we have confirmatory oral factor 11 inhibitor phase trial ongoing. And I'm sure that we will see very interesting results in the future and hopefully do more for our patient. And the most important thing is when you talk about stroke, we need to prevent ischemia, but we have to avoid the hemorrhage. And again, we are moving between Schiller and Caridi, and to find the right balance between these two terrible monsters that are waiting for us, we need to still work hard, but I think we are in a good direction. Thank you very much.
Wonderful talk, Valeria. It's hard to find the sweet spot, right?
Yes.
Yes, thank you so much. So, guys, we have several questions. We won't be able to answer all of them, but I'll just pick one, some questions for you guys, and I just so for you, let's start with you, Myra. I always pick on our cardiology colleagues and joke with them that it's a bit boring to in the evaluation of myocardial infarction, because such of a dominance of atherosclerotic disease. In stroke, we have ischemic stroke. We have such a wide range of etiological possibilities. So it's much more interesting to evaluate the etiology of stroke than MI. But the question is, would you at this point anticoagulate a patient with a multi-territorial stroke, including anterior and posterior circulation, that has a dilated, atrium and a high pro-BNP, even in the absence of like a Holter negative for paroxysmal AFib? So what's your I know we're not there yet, but right now, would you anticoagulate this patient?
So it's very tempting, obviously, to think, now since we have all this data, we observational data, we could potentially anticoagulate such a person, but we need to have the RCTs. So we need to see if really based on these biomarkers, it might be echo, or it might be blood biomarkers, which I show you right now, we can identify those who benefit most. And I think what is really important, what I learned over the last years, is really that you can go wrong with the pattern of the stroke, because it can be embolic from different sources and go in different territories. So if you have large atherosclerosis of the aortic arch, if you have an underlying occult cancer, all these can make you an embolic stroke. It's not just the heart, obviously. But these markers might help. There are surrogate markers of an increased risk of having a fib. And a fib, as I said, is not like a fib. I think it's really also important the burden of the underlying disease. And these markers, depending on the cutoff, identify those with the highest risk of underlying cardiopathy and also highest risk of recurrence. But if this hypothesis holds true in terms of reduction in stroke re-events, if you go that strategy, we have to prove that. So we have to wait for the results of these trials. It's very convincing pathophysiologically, but we have to wait for these results. So no, I wouldn't give those patients outside of the trial oral anticoagulation.
All right. Thank you so much, Myra. Valeria, there's a question for you. So in your opinion, what is your opinion about changing anticoagulation in patients with failed anticoagulation? So let's say a patient is on apixaban or rivaroxaban and then has another stroke, right? What's your approach? Are you assuming compliance? Are you check the dose, interactions? What's your take on this? I think your phone. Okay.
Thank you. Thank you very much for this question, because this is a very important point. Because when we think about adherence and compliance, if you could every time dose the concentration of the drug, we will find a lot of surprise. And I'm not sure about always the compliance and adherence as it should be, especially in older patients who don't have all the caregivers always. But let's say everything is fine. Compliance is perfect, adherence is perfect, dosage is perfect, everything. What we saw based on our data, we published this on stroke in the Reno Extend study, changing or not changing anticoagulants in a patient who have this residual risk, that does not change the outcome. So sometimes if patients ask me like psychological support to say, I don't feel safe if I continue to take the same drug. So then I forget that I'm an evidence-based doctor. Because it's important also that you get an alliance on your side and patients have to feel safe. Now there are interesting data about left appendage occlusion. There's the ELAPSE trial on top of anticoagulation if there's a residual risk. So I think this will also give us Laos 4 trial. So we will have good data on this, because I think it's not about changing the mechanism, but it's about the burden, the high burden of these patients who have, again, an ischemia. So consider that normally you have 2 for one stroke, but those who have multiple stroke, how can you evaluate? It's not a simple 2, it's much more. So in the Chatzwa score. So these are patients who have probably alteration of the heart structure, and I see a big possibility there for left appendage occlusion on top of anticoagulation.
All right, great. We have a question for Jeffrey, and also would like to hear from you all. So in your center, do you perform clopidogrel or platelet resistant testing for any patients at all? I mean, for a patient that have a TIA or stroke on clopidogrel, would you test for clopidogrel resistance, genetic testing or other tests in your center?
We do not do that routinely.
Right. What about you guys?
We did it in some patients. We had especially in young patient who came back. So it was not justified to think that a patient who had first a PFO closure, even if he was not in our department, we said, don't close it, but he closed it because for his probably he felt unsafe. But then he came back, had another stroke. So then we started clopidogrel because he was on aspirin, and then he came back again. And then we did all the resistance study. There was no resistance, but he in the end he was discharged with ticagrelor, but not really evidenced on this.
So I think so what we do is if in our center is if we have a recurrent stroke under clopidogrel, or we do look especially also if there is, for example, Asian ethnicity, because we know that there is higher proportion of mutations concerning resistance, but I would rather do then a genetic testing than the testing of the platelets, because the problem a bit with the testing of the platelets, so our surgeons love to do it, but I'm not so sure what the validity of these tests are. So maybe we can ask our hematologist what his opinion is on that. But I think if you have recurrent stroke, if you have the ethnic background, and you have like a someone who just has more events, I would do genetic testing then rather, and that's not so expensive anymore, and you can do it quite quickly. So that's not such a big issue, and I think it says more than the other way around. Of course, also if you have a genetic change, you know, it doesn't mean that the phenotype is all the same. So also not that easy. But if you have the constellation re-event and Asian ethnicity, I think you cluster a bit more of the patients where you can potentially identify someone.
All right.
I personally like to see both the genetic testing and the functional testing to link genetics,
Right.
form and function.
Okay.
They don't always correlate.
Yes. Well, folks, such a very interesting talks, and we have such a lot of questions else, but we don't have much time. And I'll ask now for our poll results. Let's check. You know, again, let's ask for the audience to answer our poll. So, what's your current level of familiarity with antithrombotic strategies for stroke prevention in patient with and without AF? How would you describe your level of understanding on how the mechanism of action of factor 11 and 11A inhibitors are hypothesized to uncouple hemostasis and thrombosis? Please answer. How would you describe your level of awareness of the current phase 3 trials? Everybody will say, I'm an expert now. In your opinion, what are the top 3 unmet needs with antithrombotic therapy providing protection for recurrent ischemic stroke in patients who are also at a high risk of bleeding? How confident are you in balancing the risks and benefits of antithrombotic therapies in AF and non-cardiomyopathic ischemic stroke patients? And the last one, how familiar are you with the use of cardiomyopathic biomarkers to guide antithrombotic therapies for prevention of recurrent stroke? All right, we can vote. Let's see the results. Well, looks like, yeah, everybody is very familiar now with the current, you know, the antithrombotic strategy for stroke prevention. Most of the people are aware or above average, understanding the mechanism of action of the factor 11 and 11A inhibitors. Most of the people would describe, you know, high awareness of the current phase 3 trials as expected. You know, several strategies have been, you know, selected now for providing protection of recurrent stroke in patients with high risk of bleeding. Well, everybody seems very confident on the benefits of antithrombotic therapy in AF and balancing the risks. And, you know, folks are familiar and somewhat familiar and very familiar with the cardio biomarkers for stroke prevention. All right. Thank you so much for such a wonderful talks and the attendance. It's going to be a pleasure. And I would like to also to remind everyone that the webinar will be online. It's been recorded, and you can always review and check on the details of the talks. And I would like to, you know, thank you again, all the speakers for this wonderful talks, and hope to see you all in the next webinar of the World Stroke Academy. Thank you so much. Bye-bye.
Bye-bye.
Bye.